Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians. Practice medicine the way you've always wanted. Data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel at VillageMD. I'm joined by Janessa Nelson, who's our legal operations expert.
Hi, everyone. Thanks for having me.
We're talking about Me Too in healthcare today. And before you turn off the podcast, because you may feel like you're inundated with some of these terrible headlines and stories, we're not focusing on the abuse, but we're really focusing on practical solutions and advice to practicing physicians. How do we respond to the changing, shifting sands that are being caused by some of these headlines? And so we're going to look a little bit at the legal issues and then also some of the clinical issues. To begin with, just as a level set, I think everybody listening probably knows that recently we read about a $215 million settlement out of the University of Southern California. We've had $500 million actually out of MSU. Johns Hopkins had $190 million. And in all of these cases, it was egregious conduct spanning many years, and the organizational response was deemed inadequate.
So now I'm worried that this is potentially one of my physicians. How big is this problem?
Well, it's a good question. And everyone in healthcare, if you have a minute, you should take a minute and go read the Atlanta Journal-Constitution reporting on this. You can find it on their website. They were nominated as a finalist actually for the Pulitzer Prize. They looked at cases all over the country. They found 3,100 cases. I think the reason why their reporting is good for physician leaders and healthcare leaders to read is because it gives you an idea of how this looks when it hits the press, because I've been involved in situations and I can tell you that they don't look like they sound later when you're in them.
Hindsight's always 20/20, right?
Right. It looks so clear later when everything comes out, but facts unfold. And you know, many times this isn't all known and fully understood when it is first reported. So the reporters were very, very critical of the organizational response and of the medical boards and the practice of letting physicians what we call quiet resignation. That is a prevalent practice throughout medicine, and many times in these cases. And so you actually, like I said, you have to read it yourself to really get it. But the problem is going to receive more and more attention. And when you read it, you sort of are led to believe we're going to have more cases before this is all sorted out.
Well, I mean, you had talked about how we're not here to talk about all the egregious misconduct. We're not going to talk about how to prevent the abuse, right? But how do we potentially screen and guard ourselves from potential misconduct?
The question isn't how to prevent it, but the real question is, from the legal question, how do you protect yourself? So this is what we recommend, is build a smoke alarm, build a detection process for abuse. And that's usually a policy. If you're a physician working with VillageMD, we can help you. Give people a way to report. Again, if you're working with VillageMD, we have many ways people can report. Open dialogue, setting a standard to say abuse is not tolerated here.
I mean, or you can just share this podcast with your friends.
Always
a great open dialogue.
Working smarter, big risk mitigator. You know, check your insurance requirements, talk to your broker, and make sure they're not exclusions you don't, of course, find these out until you need to make a claim. But the other thing that I always tell people is, you know, Janessa, when you think about these cases and you read about them, you think about some like dude in an alley, in a van,
on the train,
like trench coat guy,
giving candy to children.
And that's not the case, because those cases are not hard to believe, and if there was a creepy dude that gets reported and everybody believes it because he's creepy, it's actually, the hard cases are esteemed doctors, because people are complicated and people can be experts and be great, brilliant doctors and also be troubled. And so just knowing that, I think is a helpful thing, and making sure that you and your staff know, see something, say something without regard to who it is.
But it can be really difficult to say something sometimes if it's a friend, a colleague, someone I really like. What should I do in those situations?
That's step 2. So step 1, build the detection machine. And then step 2 is respond when it's reported. And again, this seems so basic and obvious when you're just talking about a hypothetical. Hardly anybody would say, no, if I get a report, I'm not going to respond. But you have to brace yourself to respond to the unexpected. And we have all kinds of filters and lenses and things that happen when we get surprising news. And so the way that you respond really matters, because it will drive whether people tell you things. One thing I've learned is that when something like this is going on, people tend to know.
Big Brother's always watching.
I mean, it's news, is this kind of stuff, it diffuses. And they're watching how you respond. And so you know what you know, but you don't know what you don't know. So I like to tell people to have words in their mouth, which sounds kind of funny, but so I tell people what to say. Abuse is not tolerated here. We will investigate.
If everyone wants to take a second
Just say
and
that.
repeat it.
That's just the way to say it. Abuse is not tolerated here. We will investigate. And as I'm looking at this, Janessa, I think I had a turkey sandwich on the slide that you deleted.
I cannot confirm or deny this allegation.
And I think I put it back, and I think you deleted it again.
Well, I'm a vegetarian, so I don't really like eating turkey sandwiches.
Oh, okay. Well, it doesn't have to be a turkey sandwich, but the sandwich is a metaphor. A turkey sandwich is a risk management kind of tool, which it sounds funny, but it came about because for many years I worked in hospitals, and a lot of times the cafeteria would be closed, but they always had a turkey sandwich you could give people.
Now I get it. Okay, now this all makes more sense.
So the turkey sandwich is a risk management tool because sometimes you just need to take a minute. And we used to say, with a patient, if maybe a patient was making a decision that wasn't it was irrational, they're refusing care, whatever the case may be, give them a turkey sandwich and everybody just take a minute. And that's a thing here. When you get a report, it's not credible, you find yourself starting to make observations about the accusers, just take a turkey sandwich. And it'd be great if Working Smarter had a turkey sandwich sponsor.
We're looking for sponsors, sandwich shops.
A turkey sandwich is such a soothing risk mitigator. Everyone should have one in the refrigerator at the office. So anyway, take a turkey sandwich, know everyone's watching you, commit to investigate.
Abuse is not tolerated here. We will investigate.
So, right, and then actually do investigate. But that's the way you want to respond, even if you know you don't think it's true. Moving into, again, we wanted to just give you an overview of the legal climate here. There are many states that are responding to this and enacting legislation. 4 of the VillageMD states have them: Georgia, Illinois, Texas, Kentucky. And these are mostly around chaperones. And for the most part, they require you to have a chaperone available if a patient wants it, which, by the way, is also an AMA requirement to have a chaperone available. Chaperones raise all kinds of questions that I'm certainly not qualified to answer. All kinds of practical, tactical situations come up. So I think we need to phone a friend.
I agree. Who should we call, though?
We need an expert who not only has done this, but someone we can really count on to give practical advice about the clinical impact of the Me Too movement in healthcare. So I think we should call Dr. Clive Fields.
That's perfect. Let's get him on the phone.
Let's call him. So I'd like to introduce Dr. Clive Fields, the co-founder and chief medical officer of VillageMD, also the 2018 American Academy of Family Physicians Physician Executive of the Year. Dr. Clive.
Hey, Wendy. Thank you so much for asking me to join today.
Oh, thanks for joining us. We're having a conversation today about some of the recent Me Too cases in healthcare. We're just wanting some expertise from you. What do you think of these new Stay Safe guidelines, and how do you recommend doctors address these?
Well, Wendy, that's a loaded question, and I certainly appreciate you referring to me as an expert in this area. But this is an area that's changing so quickly; it's really hard to be an expert. Most or some of what we may have been raised with or taught during residency is no longer acceptable or even applies today. And I just think it's important that doctors be aware of what's going on in their communities, what's going on in this country, and obviously what comes into their exam rooms and how that's impacted. It's interesting. I wasn't that familiar with these Stay Safe guidelines till you brought them to my attention, and they certainly make sense. And for a lot of docs, I think they're consistent with the practice that with the way they practice every day. But it doesn't hurt to just do common sense things to make sure that patients are as comfortable as possible when they see us in our offices and in our exam rooms.
I know that we were in a conversation recently and you said that your practice had these paper gowns and you had gone back to cloth because it made people feel more comfortable. Undressing is one of the, and I guess you could probably look at these guidelines and say these probably come from cases where this wasn't the standard.
Yeah, it's interesting. Most of us, when we trained, if we trained more than 15 or 20 years ago, trained with cloth gowns, and women would put on cloth gowns after they disrobed, and those cloth gowns would go to a laundry. Over time, we moved to disposable clothes and paper gowns, but I think every doctor knows how uncomfortable it is when a woman puts on a paper gown and it rips right down the front of her chest. And it's the woman usually sits in front of you with her arms crossed and is clearly uncomfortable. So I think when we get those kinds of signals from patients that they may be uncomfortable in our exam rooms, that we need to do things different. It might be the way that or the types of paper gowns that we order. It might be reconsidering going back to cloth gowns, even though there is additional cost associated with that.
Right.
But if you're getting cues from your patients that things are happening in the exam rooms that they don't appear comfortable with given today's heightened sensitivity, take those cues, change the way that you practice, think about the way that,
I think
that you do
that's
things.
such a good point, is the cues, and there's an EQ involved. Lawyers always recommend chaperones. It's also, an AMA guideline. We've got state laws about chaperones. What is your experience with chaperones? I think it can also create awkwardness as well.
Yeah, I agree. I mean, I have a chaperone in the room anytime that a female disrobes, and it makes me feel comfortable. It makes the patient, I think, a little bit more comfortable. But it is uncomfortable in other situations. So my typical practice pattern is to talk to a woman before an exam, leave the room while she disrobes, then come back into the room with my nurse. It gives me a chance to have one-on-one time with a female patient before she disrobes and puts a gown on, but I have a chaperone present anytime there is a patient that is disrobed.
Got it. What is your thinking about the gloves? I mean, the guidelines here are saying, and of course this comes from some of the facts in these cases where, the patients in hindsight realized something was inappropriate, and the fact of a physician not wearing a glove was a criteria. What is your position in your practice on that?
I think that good common sense and good hygiene leads all physicians when you examine sensitive areas to wear gloves. There's some other docs who might disagree and say that the gloves reduce the sensitivity to small abnormalities that they might be able to feel. But in this circumstance, I believe the patient's expectations outweigh any clinical advantage, and would recommend at all times that physicians wear gloves when examining sensitive areas.
That's good to know. I think consent is such an elusive and sometimes amorphous thing. In this situation, I think your point about the EQ, or just being alert to the patient's signals, is so important. But how do you handle consent before an exam like this?
Gosh, I've never seen a consent form that's covered all situations that have come up in exam rooms. And I look at consent as really explaining to a patient what you're going to do and looking for permission. If you feel that reticence in the room, listen to your gut, listen to your heart. Don't necessarily go with, quote, clinical guidelines. And especially if people are bringing different cultural experiences to the room, different geographic experiences. Some Americans, I think, on the whole, though many Europeans may disagree, are more comfortable with the body than maybe people from other cultures, more traditional cultures, maybe Middle Eastern. So always be aware of any kind of message that your patient might be sending you. Take it to heart. Understand that your cultural experience needs to be checked at the door, and that you've got to listen to the experience that a patient's bringing. They'll tell you whether they're comfortable or uncomfortable with an exam or a procedure. You've just got to listen.
I think some of the cases I've been involved with professionally where a patient perceived that they expressed, I don't want that, but maybe they didn't actually come out and say that. They may have asked a bunch of questions, or they may have shown reticence. So I like what you're saying. It's just kind of an alert awareness to that. This isn't necessarily talking about a consent form. This is kind of situational awareness, I guess, is the point.
Wendy, I couldn't agree more. Patients will tell you what they are comfortable with. It's up to us to actually look and listen.
Right. I think that's so true. And then obviously the other guideline is the obvious, sort of not making remarks about your sex life. I don't even know, Dr. Clive, if I can read this out loud, but I mean, I don't know.
Gosh, I
don't
gotta
talk
tell
about
you.
your sexual problems or fantasies. Okay,
Yeah.
that's what it says. Okay.
And that it's hard to imagine that there has to be a guideline that actually states that in plain black and white. But I think you on the legal side and myself on the medical side, we consistently see physicians make inappropriate statements, sometimes meant in humor or in
Trying
jest.
to make light maybe of an awkward situation.
Yeah, but you gotta realize, the situation you're in, and especially if a patient has just shared with you intimate details of either their physical, their sexual, their psychological life,
Right.
that there's no place for jest or jokes.
It's not the moment for the
No,
jokes.
you gotta listen. And so I would urge everybody. I mean, it's not that long ago when the internet first started that it was common to get really, really inappropriate
so
jokes
true,
that were
so
emailed to
true.
you. We know now
It's
that
so
is
true.
completely inappropriate. We didn't really realize at the time the harm that we could do, and I think the same kind of harm could be done by a physician with a poorly chosen word at an inappropriate situation when examining
It
a
gets
patient.
back to what you said at the beginning, which is the world is changing in this way, and so the patients come in with a different sensitivity. What do you think, Dr. Clive, about screening protocols?
This is an interesting one because many of us have been trained to do certain exams at a certain frequency for preventative or screening reasons. And it used to be that, if you did a well-woman exam, you did an appropriate exam, examined the woman's breasts or genital areas, that was considered all within what was expected of a normal exam. But what we're seeing now are changing guidelines, both in frequency and in the complexity of exams. So docs who rely on, my academy or my referral sources or whatever, do this as part of their routine, so I'm going to do it that way, need to be aware that these guidelines are changing all the time. And whether it's the need to do routine testicular exams, whether it's the frequency of pelvic exams, whether it's the age at which breast exams stop or start, I think docs need to be aware that you can't just rely on, I've always done it this way and that's the way I'm going to do it, because the way that you used to do it may not be the way that it's recommended today.
Well, I know as counsel, if we get an accusation, which many times can come about from a misunderstanding, it's not an intentional kind of, the first thing we look for is what's the standard for this exam? And so it's been my surprise to see, as you said, some of this changing. And I think awareness is a key, because I think a lot of patients would say, I want you to screen me for this. If there's a way to know, like they might even feel like you didn't do a full exam if you didn't.
I couldn't agree more. There's patient expectations, there's clinical guidelines, and then there's your own personal practice pattern. And sometimes they don't all line up. Some women, when I tell them after the age of 65 that we're no longer going to do routine pap smears, they're thrilled. Others, to your point, feel like we've done an incomplete exam. So explaining to a patient why you do it, why this is evidence-based, and why frequencies and complexities of exams change over time, and only helps build a patient-physician relationship.
That's good. I think the other thing we sort of touched on is just, you sort of started off with this, Dr. Clive, just about the situational awareness, the cases that I've been involved in my career. And again, I've been involved in many cases that I would just describe as a misunderstanding, where a patient did not appreciate the situation fully. Either they had a language barrier, as you mentioned, a cultural barrier. There's a change in gender understanding today in terms of gender not being binary. And so the situational awareness, which I think is something that you just really have from your experience and just your insight into how patients are feeling. How do you coach young doctors about this?
Gosh, it's a hard one because things change faster than we change. I've seen a word used a lot now, and that is cultural humility.
I think that's great.
I think it means different things to different people, but what it really means is go in an exam room, check your biases at the door. And if you know that you can't, then don't put yourself in the situation.
I guess the point is what you're thinking people can tell.
No question about it.
I always tell my children, if you think someone's stupid, they can tell.
Yeah, and I think that's actually fair. And if
Yeah.
you talk to patients in ways that make them feel like they're stupid or they're not equal in the healthcare they're receiving, I think it does. It leads to bad outcomes. It leads to misunderstanding. It leads to lawsuits. It leads
Right.
to simple little things that could easily have been discussed and resolved, leading to big, huge, ugly situations.
I think this is a big question for this issue, but for so many issues in our culture is what is the way that we can help people be more sensitive? And I don't have an answer to that, but I think, just awareness of the issue is the first step at least.
Yeah, I think even though there are many barriers and changes, that a physician-patient relationship is still very much a sacrosanct relationship,
It is.
and
It's true.
providers, physicians of all types need to recognize that. You're in a position of authority. You have knowledge on really the most important asset that a patient will ever own, their health. And it needs to be treated with that degree of respect. So don't be glib, don't be quick, don't try to make visits and interactions into social interactions. Be there for what the patient needs. And it sometimes may be more social than clinical, but many times the clinical needs should be driving the conversation and your actions.
Dr. Clive, thank you so much for joining us today about this important topic. I think this was very helpful, and I hope you'll join us again sometime.
No, thanks, Wendy. Look forward to future conversations.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.